topic of the meeting is about strategies for suicide prevention to reduce suicide rates. The first question is which individuals are at higher risk for suicide, so that we can target those individuals and plan for them. One thought we have is that 90% of people who die by suicide have a mental illness. Therefore, a logical step is to identify and treat those with mental illness, which will reduce their suicide risk. One implication of this is that access to mental health services is limited. When individuals do not have access, they do not seek help, diagnoses are not made, and treatment does not occur. Therefore, an important intervention is to increase access to mental health services, which includes psychology, psychiatry, social work, and rehabilitation services that can be part of mental health care. Another topic is that we can screen for mental illnesses. We have two types of screening. Sometimes we screen for mental illnesses in the general population, and sometimes we screen for suicide risk. There are questionnaires and tools that we use to ask individuals about this. If the risk is high, we then implement diagnostic and therapeutic measures for them. There is evidence that screening for diseases is useful, but the effectiveness of screening for suicide is somewhat questionable. Therefore, the emphasis is more on being able to identify, diagnose, and treat mental illnesses. Individuals at higher suicide risk are those who have previously attempted suicide or harmed themselves. In fact, 50% of those who die by suicide have previously made an attempt. If we want to conduct screening for suicide risk, it should be done periodically. We cannot simply categorize suicide risk as either present or absent. It exists on a spectrum. We need to triage and classify the level of suicide risk. Some individuals have a very low risk, some have a moderate risk, and others have a very high risk. For each of these groups, we need to have specific actions tailored to their needs. This is where gatekeepers come in, those key individuals in environments such as universities, communities, workplaces, or any other setting. For example, in a university, if we want to implement a program, academic members are among those key individuals. Those responsible for educational activities are key personnel, as are mentors and even staff in student dormitories. If we approach them and provide them with training to adjust their perspectives and inform them about the importance of the issue, this can be a very effective action to reduce suicide risk in that environment. How about in society? One very important action is for our general practitioner colleagues to understand the significance of this issue, knowing that suicide is identifiable, predictable, and preventable. There are many actions we can take. If we implement these actions, how many years of life can be restored to a young person who might have committed suicide? We must pay attention to this point. If we want to reduce suicide, all members of society, regardless of their job and role, have responsibilities as citizens. We need to educate them on these responsibilities so they know what to do if they encounter someone at suicide risk. One of these programs is BETA, or CPR, or Mental Health Allies, which includes self-care and other care training. These are actually items that, if we educate the general population about them, can be very beneficial and impactful. For example, in a university dormitory, all students should be aware that one of the individuals in that dormitory may be at risk of suicide. If such a situation arises, they should know the warning signs that indicate how a person is at risk, and if they identify those warning signs, they should take specific actions to reduce the suicide risk. One point that we need to be very mindful of at the community level is the limitation of access to dangerous substances. The more these dangerous substances are restricted, the less likely individuals are to attempt suicide. Currently, The most common method of suicide in society involves poisoning through pills or toxins. If there were regulations to limit these, it would certainly reduce the suicide rate. Another very useful and effective action is to reduce access to and consumption of stimulant drugs and alcohol. Studies have shown that when alcohol consumption decreases over a certain period, the suicide rate also decreases during that same period. Therefore, we need to have systems in place for precautionary treatment, especially for alcohol. Another aspect we should pay attention to is the social dimensions of suicide. Ultimately, suicide is a health phenomenon related to healthcare, but we should not limit it to just that topic. Social and economic variables have an impact on the occurrence of suicide, and we must pay attention to these issues. We need to view the entire topic holistically, considering economic, social, and medical aspects. In fact, if we take into account the risk factors for suicide, we can make a series of recommendations based on the effectiveness of these methods. You can see all these factors in this chart. We have a specific approach for preventing suicide among students at the university level, and at the ministry level, we have a national suicide prevention program, which is a very good, comprehensive, and thorough initiative. The various committees we have discussed are included in this program, and the responsibilities for each part have been taken into account. Therefore, if we all make an effort together and advance this program, we will hopefully see positive events and results.